questions in children with autism spectrum disorders that we've been working on for the last couple of years. Let's see. So, you know, just to, I think most people who have logged into this webinar are aware that when we treat autism spectrum disorders, our first-line therapy is behavioral treatments, but often we find a need for medications to help manage associated symptoms that we see, such as inattentive symptoms as seen in ADHD, or anxiety, or irritability. And irritability really comprises several common problem behaviors in people with autism, the symptoms of a very labile mood, of aggression, which might be towards others or towards themselves, and severe tantrums, which can be extremely difficult to manage. And for treatment of irritability, over the last decade or so, the antipsychotic medications have come to the front and are most often prescribed for treating irritability. The atypical antipsychotics are also known as the second-generation antipsychotic medications, are the ones that are most commonly prescribed these days in treatment of children or youth with psychotic disorders, and in treatment of irritability and autism. There are two that have been approved by the FDA, aripiprazole and risperidone, shown effective for the treatment of irritability in autism. So they were the ones that we were focused on, but in our study we were looking at any antipsychotic that might have been prescribed. Now, the antipsychotic medications are not without their adverse effects. Remember that every medication has its benefits that it's prescribed for, but every medication also has some sort of adverse effects. And with the antipsychotics, there are multiple concerns because these can be very serious side effects. The most common one is weight gain, which occurs in probably 30% or so of individuals who take this. That is closely associated with an increase in metabolic effects, the increased risk of hyperglycemia and subsequent development of type 2 diabetes, and also an increased risk of developing hyperlipidemia. The third main area that we see that we watch for in antipsychotic use is the development of abnormal movements. These fall in several categories. One is tardive dyskinesia, the area of extrapyramidal symptoms and dystonias, and then akathisia. And we're going to address that a little bit more here. So these are extrapyramidal symptoms. They can occur acutely. Sometimes they occur after only a few days or weeks of taking the medication. And when they do occur acutely, they tend to be dose dependent, especially situations where the dose was rapidly increased. When we see them acutely, they are usually reversible, and they can present as these dystonias, these dystonic reactions with difficulty with muscle movements and controlling their muscles, and Parkinsonian type symptoms where you'll see grimacing and facial twitches and involuntary movements that can be very uncomfortable for the patient. These can also occur after chronic use, a patient who has been taking the medication for months or years and never had any problems. The chronic appearance of these adverse effects is not as clearly dose dependent. Some people feel that it's related to sort of a lifetime total burden of the medication. But the biggest concern is that when they appear after chronic use of the medication, these have a tendency to persist even once the medication is reduced or stopped. So these are very serious neurologic adverse effects, and this is where we see concerns such as tardive dyskinesia or tardive dystonia. How frequent are these extrapyramidal symptoms In one 8-week study of the use of antipsychotic medications in the treatment of psychotic youth, and these were all adolescents who did not have autism, they found that more than half of them developed extrapyramidal symptoms when they were monitored closely by a symptom scale. Of those who developed the extrapyramidal symptoms, half to 2/3 required anticholinergic treatment for these symptoms, use of a medication such as benztropine or for managing and reducing those symptoms. And one of the findings of this study was that the estimates of the frequency of extrapyramidal symptoms were noted to be higher than what we see in many adult studies. So adolescents and children may be at increased risk for these neurologic adverse effects. We don't have a great deal of information on this problem in that population. As I mentioned before, those neurologic adverse effects, the Parkinsonian symptoms that may present with a tremor, a change in the person's gait, some rigidity or some slowness of movements. So these are all concerns that we need to be aware they can occur with these medicines, and we need to monitor for them. So knowing that these medicines have this increased risk of developing these problems, about 10 years ago there was a consensus development conference on antipsychotic drugs and obesity and diabetes that was pulled together by 4 major associations as listed here. And the consensus of this committee and these associations was that we should monitor the BMI, the waist circumference, blood pressure, fasting blood glucose, and lipid profile at baseline, and then monitor their weight on a quarterly basis thereafter, and lab work at that first quarterly visit, and then annually afterwards. Now these recommendations were intended for the adult population. In the report of this conference, the only recommendation they made for youth was to monitor the BMI, and they acknowledged that not a lot of information existed regarding these side effects and their management in the pediatric population. So with all of this as a background, we decided, we were going to do something about it. We looked at the literature and determined how consistently are those recommendations being followed. Well, 60 to 80% of psychiatrists report that they are monitoring glucose and lipids at regular intervals, and 2/3 of community mental health centers report that they have protocols in place for monitoring these medications. We know from quality improvement studies in a variety of areas with a variety of conditions and medications that clinicians' reports are often not quite as accurate as documentation that is seen in chart reviews or through direct observation. So the question is, how reliable are these reports? Well, it looks like they're not so good. In one study by Morato and colleagues, over 109,000 people on antipsychotic medications, they found that blood glucose was checked at baseline in about 27%, and lipids were checked in only about 10% at baseline. In another study examining nearly 25,000 people on antipsychotic medications, they found that the blood pressure was monitored 75% of the time, glucose again in that 27% range, and lipids about 20%. Now, in that study, they were looking at both baseline or at subsequent visits. So even when they were pulling in follow-up visits, the results were not terribly impressive. One of the few studies in the pediatric age group was also conducted by Morato and colleagues, and with over 5,000 adolescents on antipsychotic medication, they found that blood glucose was monitored at baseline in 31% and lipids in about 13%. So despite having these recommendations out there, they are not very well or very closely followed. So we set out to assure that we were providing best possible care and that we were monitoring these medications appropriately in the autism population as seen at our sites. So we established our study looking with a specific aim of increasing compliance of adherence to the antipsychotic medication clinical practice guideline. We didn't have a baseline clearly identified, but we thought that something like this with side effects this severe deserved to have a very high rate of reliability in being conducted. So we set that up at 95%. Now the practice guideline that we developed here consisted of monitoring the height, weight, blood pressure, and heart rate, BMI, the abbreviated AIMS scale, which is an abnormal involuntary movement scale, so that addresses the neurologic concerns that I was discussing, and then lab work to examine lipids and a fasting blood sugar. We felt that to do this, we were going to have to provide physician education regarding the best practice guideline. We also were going to need to educate staff at our sites so that they knew what these guidelines were, because really the entire staff at a clinical setting need to be involved with getting this done appropriately. And we felt that if we had best practice alerts to prompt action on the part of clinicians, that we would be able to achieve our goals. So what we saw across the sites, across the network, was that this best practice guideline was put into place. We trained physicians and nurses in performing and documenting the abbreviated AIMS at all of the sites. Sites identified a clinician champion or leader for the project at their programs. And then for those clinicians who were slow to improve, the late responders, many sites would then closely monitor them to provide them more feedback and help them change their routines. For staff education, they were taught to complete doing their vital sign monitoring. They were trained regarding the best practice guideline and why it was being put into place. And there was monthly review of the monitoring results at sites. And then finally, many sites set up a best practice alert to review and follow the lab work at the appropriate visit so that they would accomplish our goals. So as I mentioned, that clinical monitoring guideline, at every visit we wanted to see a height and a weight, and as a result of that, calculate a BMI. We also recommended getting a heart rate and blood pressure, and then the neurologic exam focusing on these potential adverse effects. We recommended using the AIMS, the abbreviated AIMS. It is an instrument that was developed for use in adults. It is not ideal for our use in our population, but there wasn't anything else that was better, so we thought we would start with it. And then as part of our guideline, we were recommending that we do these at baseline and at 6 months and then yearly in terms of doing blood work for the glucose and lipid profile. Recall again that the consensus standard gave no recommendations in the pediatric age group, so we did this based on consensus and feeling that this seemed to be an appropriate conservative method of following it. And so on this slide you see an example of the monitoring sheet that we used at my institution at Nationwide Children's, where we would do chart reviews, ideally of 10 charts of each clinician who's managing these medications, as you see here. A clinician who's seeing fewer patients during the monitoring period might have, as in this case, only 7 charts. And we monitored for all of those 8 indicators. I'm going to come back to this as an example later on, but I want to show you what we were monitoring across the network. So here is how we were scoring performance at each site. For a patient who comes in who is on an antipsychotic medication, here are the 8 indicators that we want to measure. For our purposes in this study, we clustered them into the vital signs: height, weight, blood pressure, heart rate, and calculation of BMI. These are factors that are generally done by a nurse or medical assistant who is placing the patient in the room and preparing them for the clinician to come in and see them. So we clustered the vital signs as one area, and it's worth 1 point if it is done. The next one is conducting the AAMs, looking for abnormal neurologic movements. And then the third component was the lab work. So in this example, you see that patient 1 has everything done. We see each of them was accomplished. And so patient 1 ends up with a score of 3 out of 3, the maximum score that they can get. If we look at patient 2, we're missing some data here. And so we do not have the vital signs completed. We do not get a point for that. We do get a point for the AIMS, a point for doing the blood work. So this patient, we're going to give the clinician a score of 2 on this. Now, as we look at some of these others, you see patient number 3, we were unable to get some information on. Patient 4, we also are missing information. And patient 5, we ordered lab work, but we don't have results. Now, these are scored a little bit differently. If we ordered it, or if we attempted to do something but we couldn't do this, we give credit to the clinician that they are trying to do the right thing. They're doing all of the things they're supposed to do. For reasons beyond their control, they are unable to do that, but they have done the right thing. So in this case, where we have documentation, you see that they get the full 3 points possible. But if there is no documentation, then they lose that section or that point. As many of us know through insurance audits of medical records, if it isn't documented, it didn't happen. And we followed that same philosophy. So for this patient, you might score this patient or this clinician as having an average score of 2.6. We could convert that to a percentage as well, but this is how we were examining how clinicians were performing and then how a site was performing by averaging all of these and 2.6 divided by 3 and getting that percentage score. So what did we find? Well, some of our sites had already started doing antipsychotic monitoring prior to us starting our learning collaborative, and the sites had varying degrees of success depending on how long they had been doing it and how concerted their effort was to do this consistently across all clinicians and all patients on these medicines. Some of our other sites, as part of their regular clinical work, do not manage the medications for many of these patients. When they didn't have many patients on these medications, it was difficult for them to develop this new routine because they didn't have enough repetition and practice to get it going well. Some of them, because they managed so few, had not seen a need to have such a best practice in place. So some of our sites were coming into this with very different situations. What we did see across the study was that all of our sites participated and demonstrated some improvement over the course of the study. So here's an example of one of the sites, and this is a P chart, a percentage chart. You can see that in the beginning, early on, their baseline average was about 66.7%. They were able to incorporate the guideline into their electronic medical record and started seeing improvement. They established a team lead to really champion this change in the routine, and with some of the changes that they made in their clinical practice, their routine, getting everyone on board, over time, they got their average up to almost 90% during the course of our collaborative. Here's another site that started at about 76%. You also see a lot of variability here from month to month. They were able to also incorporate this into their electronic medical record. They also revised how they were monitoring their data, and we saw an improvement from around 76%, eventually up to an average of 94%. But what you can see here is that over the last 3 months of the collaborative here, they were hitting about 100% every month. So they had really shown an effective incorporation of this into their regular process. Here's another program that was doing this already when we started the collaborative, and they were doing it at a pretty high level, but they also had quite a bit of variability. And so one of the goals of good quality improvement is to increase that reliability and reduce variability. Among the strategies that they used was having the nurses assist the providers with documentation. This method of having people watch your back, of making sure that you remember to do things, is another common quality improvement technique in the healthcare field, where we see something that's happening or not happening, and we prompt that provider, say, did you forget to do this, or did you mean to do this? And that helps providers change things so that they correct their mistakes. And so with a variety of changes that were incorporated into their program, they were able to improve what was already a very good score up to an even higher level. And then here are some brief charts summarizing what we saw at the other sites across the network. You see a variety of patterns here. Again, they reflect how closely this is monitored, how it's incorporated, and how much it has really been integrated into the system. For example, at this site, they were doing very well until one certain clinician left the program, and their performance dropped. And it turned out that others were following that clinician, and that clinician was seeing most of the patients on the medicines. So their overall performance as a site dropped because it was really part of that clinician's regular practice, but they didn't have the checks and balances and other changes in their system to really integrate it in so that it was being done very reliably on a high percentage of patients. So, factors that we found in the success of the project: we had our improvement with our monitoring when we, first of all, developed a best practice guideline that everyone could follow. We developed standardized procedures and tools for tracking this at our sites. We have sites that have electronic records and those that don't. We educated the staff and families, and then those sites that had strong leadership and advocacy were the ones that were able to make the most changes. Now, next steps that we would look at would be some more precise monitoring and scoring, and I'm going to show you that on the next slide. But also, programs need to have further modifications to help assure their sustainability. And then we plan to continue with similar activities along this line, addressing other components of our care. So one of our areas of emphasis during this coming round of the ATN is going to be focusing on transition planning, for example, and documentation that we are addressing transition issues in certain patients at certain times is one of the things that we will be developing as time goes on. So briefly, this is a slide I showed you before, and if we look at this clinician here, physician number 1, had 10 charts reviewed and did pretty good on these, but there were 2 patients where they didn't have blood pressure and heart rate. So we've got a total of 10 patients times 8 indicators. That's 80 potential points, and we lost 2 points here and 2 points here, so we lost 4 out of the 80 points. So this clinician got a score of 95%. And when we score things this way across all of the physicians at the site, it looks pretty good. However, another way of looking at this is if you didn't do all of these indicators correctly, the full vital signs, for example, if you didn't do them all correctly, then you just didn't do it correctly. This is an all or nothing approach. And so if you didn't do all 8 correctly, you might get a 0. If we look at it that way, physician 1 got 8 out of 10 correctly for a score of 80%. And when we look at it in this much more refined and rigorous scale, we find that then this group of clinicians is performing much lower at a 65% level. So it's this kind of further refinement and expectations that we're going to be looking at as we continue to try to improve our care incrementally. I want to thank everybody at the CCC, especially Kirsten Klotka and Jim, the folks from Autism Speaks and NICHQ, and all of the leaders at our sites for all their help with this study. And with that, I think I'm going to turn things over to Dr. Micah Mazurek, who's going to tell us about sleep problems in children with autism and the role of anxiety and sensory over-responsivity.
Great. Thank you, Dan. Okay, well, thank you so much for attending today. I'm excited to talk about the results of this study that we just completed using ATN registry data. And we'll be talking today about sleep problems, anxiety, and sensory problems specifically. So I'd like to start with what's probably going to be a review for most of you on the call today, but just to highlight the importance of understanding symptom complexity in autism. We know that autism is comprised of core symptom areas, so those include deficits in social communication and interaction skills, as well as restricted and repetitive behaviors. And those are considered to be the core symptoms of autism spectrum disorder. But we also know that autism is a very complex disorder that's associated with lots of other co-occurring problems. So we think of those as being comprised of medical complexities, things like sleep problems, GI problems, seizures, but also psychiatric symptoms like anxiety, challenging behaviors, and cognitive problems. So all of these co-occurring difficulties are very important to consider when we think about really helping children to achieve the best quality of life, and also when we're thinking about understanding the nature of ASD. We also think about the clinical significance of these problems as being very important when we think about treatment. So we know that co-occurring problems can exacerbate core symptoms. For example, a child who has a lot of anxiety may demonstrate an increase in repetitive behaviors. These kinds of symptoms can also interfere with treatment response. So if a child is exhibiting lots of challenging behaviors, they may not be able to sit and attend to therapies or participate in the classroom as well. They can also lead to increased family stress and burden. And we know that that can happen above and beyond the effects of core symptoms. So sometimes these co-occurring problems are really adding an additional layer of stress and burden for not only the child but also their families. And then that leads to reduced quality of life. So I think the clinical significance is very apparent when we're thinking about co-occurring or comorbid conditions. But they can also provide really valuable insights for us into the nature and potential subtypes of autism. So if we think about characterizing children by their pattern of co-occurring problems, it may tell us quite a bit about potential subgroups of children underneath that autism umbrella that may respond differently to different types of treatment. And then that could also lead us to know a little bit more about etiology for subgroups of kids. So one of the symptoms that I'm going to be talking about today that's a very common co-occurring problem for children with autism is sleep problems. And most of you on the call today will probably recognize the importance of this issue if you work with children with ASD or are a family member of someone with ASD. You know that sleep problems can be very common. The prevalence appears to be between 50 and 80% of children with ASD who are affected by sleep problems. You can see a few different reviews here that have different estimates within that range. And we know that lots of sleep problems are common for children with autism, but probably the most common types of problems are difficulties falling asleep and waking up at night. We also see some evidence for disturbance of circadian rhythms. So as you might imagine, sleep problems can have a pretty significant impact for kids and families. At the level of the individual child, we know that sleep problems can have really negative effects on learning and academic performance and cognition. So I know that when I don't get a good night's sleep, I'm not at my best thinking capacity. So that's also the case for our kids with autism. We can also see exacerbation of stereotyped behaviors for children who are sleep deprived, and they may also show an increase in challenging behaviors. And so that then leads to just a reduced overall well-being or quality of life for kids. Sleep problems can also have a pretty clear impact on the quality of life of family members and parents. So if the child's not sleeping well, we know that parents have trouble sleeping, they're experiencing increased stress, and just overall reduction in well-being for parents. So I think the clinical impact of sleep problems, again, just as with all the other co-occurring problems we talked about, these are very important to consider. So what do we know about the causes or the etiology of sleep problems in autism? There have been a number of really important studies coming out in the past decade on understanding sleep problems in autism. Many of the folks who are part of the ATN sleep committee have been active leaders in the field in this area. And so we know that there are probably lots of different causes for sleep problems in autism. Some of those may be medical problems. They may include medication effects and those kinds of things. We know that for some children, difficulties with circadian rhythms or melatonin regulation can play a role. Sleep hygiene can also play a role in the development and maintenance of sleep problems. Some of the core symptoms of autism sometimes make it difficult for children to develop sleep routines and things like that. So these are some causes that we're aware of. But there's also another potential mechanism that has been discussed at a theoretical level that has not received as much empirical attention, and that's the idea of hyperarousal as an underlying mechanism for sleep problems. This idea is very compelling for a lot of different reasons. One of the primary reasons that we think it's important to consider is that there's quite a bit of literature in the general population indicating that hyperarousal is associated with insomnia for typically developing adults and children. And so from those general population studies, we can see that adults and children with insomnia show indicators of hyperarousal at the autonomic arousal level, also when we think about cortical excitability and indicators of HPA axis involvement. So those are all some things that we know from just general population studies on sleep difficulties. And there's also quite a bit of research showing that anxiety is highly related to insomnia in the general population. And we can think of anxiety as an arousal-related symptom because we know that it is also associated with high arousal levels for people who are affected by anxiety. So some of these cross-sectional studies are showing us that insomnia is related to anxiety at a cross-sectional level, but that it can also be a longitudinal predictor of sleep problems. So I think this really highlights the importance of considering arousal and anxiety in thinking about sleep problems for people with autism. Another reason that I think this is a compelling argument is that we also see arousal dysfunction in the autism population outside of sleep. So we know that children with ASD seem to be at increased risk for lots of arousal-related difficulties, and we found that with some emerging studies looking at physiological measures like heart rate or skin conductance at baseline, but also in response to stimuli, we're seeing differences when we're comparing children with autism to typical kids. And we also know that people with autism are at really high risk for things like anxiety and sensory over-responsivity. And again, those are really considered to be arousal-related symptoms. So I think all of these findings lead us to think about considering anxiety and sensory problems as being important variables when we think about sleep problems. So I want to just take a minute and talk about definitions of the terms that I'm going to be using. Anxiety, in the context of the talk today, is going to be referring to responses to stimuli in the environment that are real or perceived threats. Anxiety is typically thought to have three different components that are comprised of physiological symptoms like increased heart rate, things like that, cognitive symptoms like worry or fear, and then behavioral components that typically include avoidance of certain situations. We know that the prevalence of anxiety in autism is very high, so studies range from 40 to 84% in terms of prevalence of anxiety in children with autism. So it's an important consideration for this group. And I'm also going to be talking about sensory over-responsivity, or SOR. And this refers to a subset of sensory difficulties that include negative responses to stimuli. So it's really defined as having distress or avoidance or hypervigilance to sensory stimuli that could include visual stimuli, auditory, or tactile. Again, this is very common in children with autism, with prevalence rates between 56 and 70%. So just to give you a definition of what we're going to be talking about. And both tend to be more common in children with autism than in the general population. So we know that actually SOR and anxiety are strongly related with one another, both in autism populations and in the typical population. But they seem to be representing distinct constructs. So we're not, anxiety is not the same thing as SOR, but they're highly related to one another. Which has led people to think that maybe they represent constructs that share underlying mechanisms. And again, both of them are associated with arousal and HPA axis involvement. So it relates really directly to this hyperarousal construct. Which leads us to think that this, again, may relate directly to sleep disturbance. So despite the fact that this idea seems very compelling and there seems to be good rationale for thinking about hyperarousal in this population, there have been really very few studies in children with autism to date. But we are finding some correlational studies looking at the relations between at least subsets of these variables. So we're starting to see evidence that anxiety is associated with poor sleep in some groups of kids with autism. And there's been a recent study in 2012 showing that sensory problems and sleep problems are associated with one another in autism. So based on this previous evidence from the general population and some of these emerging studies, there's good reason to think that SOR and anxiety may be related to both development and maintenance of sleep problems. But there have been no previous studies that have looked at all three of these variables to see how they may relate with one another. So the purpose of our study was to do that. And we proposed three hypotheses related to this question. First, we expected that sensory over-responsivity would be associated with anxiety. And then secondly, for our second and third hypotheses, we predicted that anxiety would be associated with more sleep difficulties, that SOR would also be associated with greater sleep problems. And then finally, when we included both of them in a joint model, we expected that each of them would be associated with specific types of sleep problems. So the methods for this study really leveraged the rich data set that we have access to in the ATN. And we looked at data from over 1,000 children and adolescents who are enrolled in the ASATN clinical registry. We had a pretty wide age range from 2 to 18. The majority of kids in our study were male. And the primary measures we were interested in relate specifically to those variables I've been talking about. So we used the short sensory profile, a subset of items from that measure, to look at sensory over-responsivity. We looked at the anxiety problem scale from the CBCL, and then we examined subscales from the Children's Sleep Habits Questionnaire, or the CSHQ. And in terms of our analysis plan, for our first 3 hypotheses, we used correlations to examine the bivariate relationships between these variables. And then for our final hypothesis, we used a path modeling technique to fit a single model with our sleep subscales as dependent variables, sensory problems and anxiety as independent variables, and then we included IQ, age, and gender as covariates in those models. Okay, so I'm going to present the results now, and we did these results separately by age group, primarily because the anxiety measure that we were interested in is different depending on the version of the CBCL that was used. So we have an age group for ages 2 to 5 based on that CBCL version, and the older age group is 6 to 18. So I'm going to present the results separately for those age groups. So this is just a correlation table that's showing the bivariate relationships between these variables. And you can see that as predicted for this younger age group, anxiety and sensory over-responsivity were highly correlated. Just as a side note, this SOR scale is scored in the opposite way as the anxiety scale. So lower scores on this measure indicate more difficulties, while higher scores on the anxiety measure indicate more difficulties. And so you can also see that we found support for our second and third hypothesis in this group, finding that anxiety was related to all of the sleep problems that we were interested in looking at, including bedtime resistance, sleep onset delay, sleep duration, sleep anxiety, and waking up at night. And that was also the case for sensory over-responsivity. And the effect sizes seem to range from small to medium for this younger age group. For the older age group, we found the same pattern of results. So again, we found support for all 3 hypotheses. It appeared that the effect sizes were a little bit smaller for this older age group, but again, because we had such a large sample, all these correlations were statistically significant, although small in some cases. So those were the results from the bivariate analyses, and now I'm going to take a minute and talk through the results from the path model. Okay, so this slide illustrates the results of the first path model for the younger age group, ages 2 to 5. And this is kind of a busy slide, so I'll talk you through what we're looking at here. So here on the right side, we have our dependent variables, which include all of the sleep subscales that we were interested in looking at, sleep onset delay, bedtime resistance, night waking, sleep duration, and sleep anxiety. And then on the left side, we have our 2 primary independent variables, sensory over-responsivity and anxiety. And we also have the covariates that we included in this joint model, sex, age, and IQ. And here in this box, you can see our model fit statistics. And these show really good evidence of good model fit for this model. And I know this was a very busy graphic, so I'm going to walk you through what we found with regard to our target variables. So when we're thinking about anxiety specifically, for this younger age group, we found evidence that even within this joint model, accounting for all the other relationships among variables, anxiety was significantly related to all of the sleep variables that we were interested in. When we looked at sensory problems, they were specifically related to sleep onset delay, night wakings, and sleep duration, but not with bedtime resistance or sleep anxiety. So it appears that these 2 sleep-related variables are more closely associated with anxiety for this younger age group, while sensory problems also play a role for these additional 3 sleep variables. Okay, so that's the model for the younger age group, and we did the same analysis for the older group. And again, this is a very busy slide. You'll see that the model fit statistics, again, are very strong. It looks like the model fit the data well. Similar to the younger age group, we found evidence that anxiety is significantly associated with all 5 types of sleep problems, and that sensory problems are associated with 4 out of 5 of these sleep difficulties in the older group, but not with night waking. So in summary, we found support for our first 3 hypotheses regarding bivariate relationships. And we also found that when considered jointly within this multivariate model, anxiety was very strongly associated with all of the sleep difficulties that we were examining, while sensory responsivity was associated with certain subsets of symptoms depending on age group. So in terms of the conclusions from this study, we do think that it provides good evidence that children with ASD who have anxiety and SOR are at increased risk for sleep problems, just as we predicted, and that would be consistent with previous evidence on that topic. And the results do provide some preliminary support for this idea that hyperarousal may underlie sleep problems for many children with autism. And we're hopeful that this knowledge will really inform future research that will include lots of different kinds of measures as we look at different measures of arousal and sleep difficulties. So some of our future plans are to include studies that will involve physiological measures of arousal, as well as objective measures of sleep, because one of the limitations we know about our data currently is that we relied on parent report of all of our variables. So we want to have a multi-method, multi-informant kind of approach so that we can get different indicators of our variables of interest. We also hope to use this data to inform longitudinal design so that we can help understand patterns of symptom development over time. And ultimately, we hope that this will help us develop new treatment models for targeted symptom treatment and potentially focusing on arousal when we're trying to help kids with autism who have sleep difficulties. So I want to thank you for your attention and thank the ATN for use of the data and support of this project.
Thank you. We actually have a couple questions for you, Micah.
Okay.
So what ages was the short sensory profile normed?
That is a great question. I'm going to have to look back to my notes and see what the original normative sample included. I know that the sleep measure was not normed up to age 18. I think the top of the normative range for that measure is age 14, but it has been used in older children. For the short sensory profile, I think we're within the normative range, but I'm going to have to check on that to get back to you guys. So if somebody has a question and wants to send me an email, I'm happy to get back in touch.
Okay, and just another quick question about the SOR category. Which sensory systems were included in that category?
So that was a subset of subscales from the short sensory profile. And we looked specifically at the sensitivity items. So that included tactile sensitivity, taste, smell sensitivity, movement sensitivity, and visual auditory sensitivity. So it was a total score of items from those particular subscales.
Okay, great. Thanks. I wasn't sure if anyone had any additional questions, if you wanted to type them into the question box, or if anyone wanted to chime in via phone. We have a couple more minutes. And if not, you can always send questions via email to me, and I can reach out to the presenters. And if nobody has any questions, then just a quick reminder that an evaluation of this webinar will be sent to everyone via email, and its completion is required if you'd like to receive CME credit for attending today's webinar. So just thank you everyone for attending, and thank you to our presenters, and we hope to see you at our next month's webinar.
Thanks, folks.
Great, thank you.
Thank you.
Bye now.